Dr. Mohammed Albeshir. He is an advanced endoscopist um, uh, at King Fahad Specialist Hospital. And today he will talk to us about gastric neuroendocrine tumor.
Thank you, Ammar. Thank you both, Ammar, for chairing this session. And thanks for the organizing committee and Dr. Imad for the kind invitation. It's given me a great pleasure to be, an honor to be part of this amazing program. So, so hopefully, by my end of my talk, everyone here will be able to define and classify type of gastric neuroendocrine tumor and understand the epidemiology of it, and list the endoscopic treatment options available, and finally go home with a simplified approach or algorithm for endoscopic treatment of gastric neuroendocrine tumor. So generally, GI neuroendocrine tumor or gastropancreatic neuroendocrine tumor comprise a spectrum of widespread heterogeneous epithelial neoplasm that usually have predominant neuroendocrine differentiation. They can be generally classified into pancreatic and gastrointestinal. Gastric neuroendocrine tumor itself can be subclassified into three main types according to the WHO classification. So type 1, which is the most common type, it's usually associated with chronic atrophic gastritis or autoimmune gastritis, typically small, typically multiple lesions, and they usually have very excellent outcome and prognosis. Type 2, which is the least common type of gastric neuroendocrine tumor, it's usually associated with hypergastrinoma syndrome and usually caused by excessive gastric production. It has a favorable prognosis, but it does sometimes metastasize in less than 30% of cases. Type 3, which is the more aggressive type with a different biological behavior, it's a sporadic lesion, it's usually single lesion. It constitutes around 25% of cases. It does have poor prognosis, so careful decision and careful selection of those patients with regard to the best possible treatment is usually recommended. The classification according to WHO based on the differentiation and based on the mitotic rate and K67 index. I'm sure you guys are aware about it. But from G1 to G2, they are all well differentiated. The difference between them is usually related to mitotic rate and K67 index. Obviously, the higher the mitotic rate, the higher the K67, the more risk of malignancy and metastasis. There is another type which is called type 4, but it's usually neuroendocrine carcinoma. It's not usually neuroendocrine tumor. We'll talk about it briefly, but it has a very poor prognosis, and there is no rule for endoscopic management in this type of neuroendocrine carcinoma. So generally, GI neuroendocrine tumor have an incidence for approximately 4.7 per 100,000, usually common in the 40-60 age group. Usually, according to North American study, it's more common in African American than Caucasian. It's more in male than female. But what about gastric neuroendocrine tumor in particular? It's constitute around 8% of all GI NETs or GI neuroendocrine tumor. It's actually the third most common site after rectum and small intestine. The incidence has significantly increased in the last decade or so, and the mean age is around 50 to 60. Usually type 1 has a more female predominance, but type 3 usually equal gender distribution. Obviously, the rising prevalence and incidence are related to widespread use of endoscopic screening program, high awareness, and aging population as well. So the incidence, if you look at the surveillance epidemiology end result data that looked at the incidence for neuroendocrine tumor in the last few decades, the incidence has been rising over time globally, not only in certain part of the world, from 1.09 per 100 population in 1973 to almost 7 per 100 population, per 100,000 population in 2012. Interestingly enough, the neuroendocrine tumor prevalence in the US was the second most common GI tumor after the colon cancer. And according to the SER database, among stage group, the incidence is increased the most in the localized type of neuroendocrine tumor, so the early stage of neuroendocrine tumor. And among grade group, as you can see here, the incidence increased the most in G1 neuroendocrine tumor, According to the site, among site, prevalence was highest in the rectum, followed by small intestine and stomach with regard to GI neuroendocrine tumor. So how do they present? They varies from asymptomatic incidental finding to a classical carcinoid syndrome, or sometimes symptoms can be related to direct effect of the tumor to the GI tract. They might present with pain, intestinal obstruction, GI bleed. The problem is they have vague abdominal presentation and they can sometimes be labeled as IBS. Unfortunately, neuroendocrine tumor usually diagnosed late, and when they diagnose late, it's too late to do any endoscopic or surgical management. So just go briefly on more detailed characteristics of types of gastric neuroendocrine tumor, just to refresh everyone here. Type 1, again, usually asymptomatic, usually discovered incidentally, again associated with chronic atrophic gastritis. Usually multiple small polyps, less than 1 centimeter. They have yellowish surface and smooth surface. Rarely cause carcinoid syndrome. They're associated with pernicious anemia and B12 deficiency. Type 2, multiple small polyps, again associated with either Zollinger-Ellison syndrome or multiple endocrine neoplasia syndrome. Type 3, usually sporadic, usually solitary, has no relation to gastrin level and has no relation to hypergastrinemia, and it has arise from a neoplastic transformation of ecocell echochromographine cells without underlying any gastric pathology. Type 4, which is a neuroendocrine cancer, it's the worst type. It can be a small cell or large cell variant. It's usually present with advanced disease, usually large ulcerated lesion with rapid growth, and usually have lymph node and vascular invasion. Looking at the natural history and the prognosis, obviously grade 1 has the most favorable prognosis and the 5 years survival. They have the lowest metastatic risk over 5 years in comparison to type 2 and type 3. So how to diagnose? Gastrin level is not helpful in diagnosing gastric neuroendocrine tumor, but it does help you differentiate the type, which is important in deciding what the management approach. Chromogranin cannot be recommended as a screening test due to its low specificity. However, it's a tumor marker that might be helpful in type 3 gastric neuroendocrine tumor. It can be helpful and can usually correlate with the burden of the disease, with the presence of liver metastasis, and it's also helpful as a prognostic test to monitor response to treatment. It does affected by many factors, liver function, kidney function, and PPI as well. So what's the role of endoscopy in the management of a neuroendocrine tumor? A gastric neuroendocrine tumor in general, they can present with either polyps, nodule, ulcerated lesion. They can be single or multiple. They can have a smooth surface or an ulcerated surface as well. EUS has the greatest sensitivity for tumor detection when you compare it to other cross-sectional imaging. It's usually recommended for any gastric neuroendocrine tumor more than 1 centimeter in size, and it's particularly recommended and essential in type 3 neuroendocrine tumor to assess the depth of invasion and to see who to select for possible and potential endoscopic resection. Neuroendocrine tumor, gastric neuroendocrine tumor is always in the differential diagnosis of any submucosal lesion in the stomach, and you guys all know that. So again, gastric neuroendocrine tumor type 1 and type 2 usually less than 1 centimeter in size, type 3 more than 1 centimeter. They are usually type 1 and type 2 favorable grade, type 3 is usually unfavorable grade. And type 1 and type 2 usually involve the superficial mucosa and submucosa, but type 3 can involve any layer of the gastric wall. That's why EUS is essential in assessing type 3 lesion. So when to do endoscopic resection? It's according to the European Neuroendocrine Tumor and the NCCN, type 1 less than 2 centimeter, grade 1 or grade 2, and with less than 5 lesions, and type 3 less than 1 centimeter with grade 1. Those type of lesion can be considered for endoscopic management. I'll go quickly over that. Again, Dr. Rashid already mentioned that with regard to gastric cancer. EMR does have a significant role here in the management, in the endoscopic management of neuroendocrine tumor, given its small size. standard MRI or cap-assisted or band ligation EMR, simply sucking the small nodule lesion and in a rubber band and cutting under the rubber band will provide you with hopefully in-block resection. However, EST, when you compare it to EMR, although there is no direct comparison, there is no RCT, but the outcome based on observational study showed that the in-block resection with EST in neuroendocrine tumor reaching up to 98% with an R0 of 95%. Endoscopic full thickness resection enables complete resection involving even the muscle layer or deeper layer. Two way of doing full thickness resection for gastric neuroendocrine tumor: the full thickness resection device, which is simply a modified Ovesco with an integrated snare. You suction the lesion and you cut, and you ensure that the clips is there to ensure and close the perforation defect. There is also a new approach which is called LEX, or laparoscopic and endoscopic cooperative surgery, where you combine the surgeon and the endoscopy. It's helpful when both surgeon and endoscopics, it involves doing it in the OR, obviously, inserting a trocar. The endoscopist part removing the superficial layers, the surgery part remove the seromuscular dissection, and then the defect will be closed later on. This is an example of the full thickness resection device. You can see here the submucosal lesion. You can see here the Ovesco clips fired and the photo on the top left after resection, with ensuring that the Ovesco has closed completely the perforation defect. When you compare the different techniques, you can see reasonable outcome both for EMR and EST and full thickness, particularly for lesion less than 1 centimeter. But once the lesion goes above 1 centimeter up to 2 centimeter, then preferably we prefer proceeding with EST and full thickness resection, as it does both of them achieve a higher rate of R0 resection and in-block resection. To summarize, if you have a gastric type 1 neuroendocrine tumor, you assess the size less than 1 centimeter. If it is less than 5 lesions, if it is in the superficial mucosa, then endoscopic treatment approach is recommended. If you achieve an R0 resection, you involve them into a surveillance program. If you have a positive margin, then you upgrade your endoscopic resection to, if you did an AMR, you go with EST. If you did an EST, you go for thickness, or you move on for surgery. If you have a lesion more than 1 centimeter, then EUS has a rule. If the lesion is deep, involving the muscle, then surgical approach. If not, then endoscopic approach. For type 2 and type 3, type 2 usually managed similar to type 1. However, usually in type 2, the treatment is usually addressed on the underlying syndrome. But for type 3, we looked at the size. If the size is less than 1 centimeter with favorable grade, then endoscopic resection is recommended, favorably EST. If the lesion is more than 1 centimeter and if the grade is unfavorable, then surgical resection with gastrectomy and lymphadenectomy is recommended. I'm concluding. That's it. That's my final slide. So for surveillance, if you have an R0 resection for type 1, then you can bring them in a year and repeat endoscopically annually for a couple of years. No role for cross-sectional imaging. For R1 resection type 1, then consider other treatment option or endoscopic option, or involve them in a screening program and surveillance. If you end up with only deciding surveillance, there is no role for cross-sectional. You can do annual endoscopy only. For type 3 with post-endoscopic resection R0, you can bring them frequently, as they tend to have more biological, more aggressive behavior and tend to have metastatic disease. And they need to be monitored with endoscopic and cross-sectional. Thank you very much.
Thank you, Mohammed.